Hello, everyone, and thank you for joining us this afternoon. This is our third part in the COVID-19 Keeping Up with the Moving Target series, and we're excited to welcome you to our session today. Over the next hour, we will be discussing clinical aspects of COVID. And so without further ado, I'd like to introduce first our moderators, Ramesh Atakari and Jose Mercado. I want to thank them both for joining us, and they've got beautiful qualifications here, and I'm excited to see how they lead this discussion. Ramesh, Jose, take it away.
Good afternoon, everyone, and welcome to COVID-19. Our faculty for today includes Dr. Ibrahim Barkuda. Dr. Barkuda is the Associate Director of Hospital Medicine Unit at Brigham and Women's Hospital and an Assistant Professor of Medicine at Harvard Medical School in Boston, Massachusetts. Welcome, Dr. Barkuda.
Thank you for having me.
Next is Dr. William Garneau. He is the Assistant Professor of Medicine at Division of Hospital Medicine at Johns Hopkins Hospital in Baltimore, Maryland. Welcome, Dr. Garneau.
Good to be here.
Thank you. Last but definitely not the least is Dr. Paul Atwater. He's the Clinical Director, Division of Infectious Diseases at Johns Hopkins Hospital. He's also the past president of the IDSA and Professor of Medicine at Johns Hopkins University School of Medicine from Baltimore, Maryland. Welcome, Dr. Atwater.
Yeah, thank you, Dr. Mercado, and delighted to have an opportunity to speak today.
In front of you are the faculty disclosures, and I would like to let everyone know that all activity content and materials have been developed solely by the activity directors, planning committee members, and faculty presenters, and are free of influence from a commercial entity. Our learning objectives include discussing findings from randomized clinical trials for treatments in hospitalized COVID-19 patients, evaluating current guidance for treatment of COVID-19 patients requiring hospitalization, and understanding recent recommendations regarding the diagnosis and prevention of VTE in hospitalized patients with COVID-19.
Thank you, Jose. I want to remind everyone in attendance that you will receive an email with instructions to claim your CME credits for attending 24 hours after this session ends. And for reference, the information is here. Once again, 24 hours after the session, you will receive instructions to claim CME credits.
Thank you, Chris. Thank you, Jose. Thank you, everyone, for attending the webinar. Our first presenter is Dr. Ibrahim Barkuda, and our first topic is COVID-19 treatment and clinical care. Dr. Barkuda, it's all yours.
Thank you. Thank you, Ramesh. Thank you, Society of Hospital Medicine, and the sponsor for this talk. So, my goal in the next 7 minutes is to set the stage for my esteemed colleague to carry on with the content. But let me start with this phone picture I took now over a year ago. We started this not knowing how our journey would be. We were at the front line. I'm one of those privileged ones that my hospital and my colleague were at the front line, and I was with them, still with them, with the nurses, and the science and everything been built forward. And with this, we'll bring you more of that content where we started last year is not what we're doing to help our patient, what we're doing for our patient. Next slide, please. So always with the updates, the CDC reports the daily admissions for us for the US, and the daily admission specifically when it comes to COVID-19 is based on the confirmed cases, and we're still hovering between 5,000 to almost now 7,000 with the spike that you heard about in Michigan and other states, but we're still in it. The end of the tunnel seems to be closer, but we still have cases in our hospital that we're trying our best day in, day out to make sure we give our patient the top-notch, the updated science. Next slide, please. So with this, we know that the daily trend, and that is positive SARS-CoV-2, it's still in the range, as you could see, between 70,000 plus, but the death, unfortunately, it's still hovering around 1,000. It dropped below 1,000, but that is not a number that been the norm. The norm was 0, and hopefully we'll get back there with the vaccination and the updated treatment guidelines. Next slide, please. What we know also about our spread, and this is outside hospital medicine, but would be the extension of the cases we see within hospital medicine, is the age brackets of the infection. And you see these green lines, the age brackets in the 20s and 30s, they driving the cases of SARS-CoV-2 infections, and later on that would be the cases that probably spreading more in the community, but our admission demographic is a little bit different. But just for you to know that the guidelines to keep the mask on and hopefully curb this forever, it's still in effect. Next slide, please. That led me to think more about what would be the weekly death in really the age bracket. So please remember, even though we're still seeing cases on the younger side in the demographics that we're admitting to our hospital, that the age bracket of 80 and older still driving that admission and unfortunately the subsequent death of that, and that slide getting updated every week from the CDC. Next slide, please. So this slide, Dr. Atwater will add on it, but I want you just to get the flavor of the variants that we're now testing. It's different than the wild variant that where we started the pandemic, that raising the flag day was now quite different of what we see in their newer variant emerging, the P1, which is the one that you're hearing about in the news often. It's not there yet, but the fear always that the UK variant, which is the B1 that you see here, it's growing, it's more contagious, and the reports we're getting are more lethal, unfortunately. So I would like to start with this case where this will be changing with the vaccination. It might not really change what we do dramatically in the hospital, but again, just state what we know from the guidelines, from the guidance, and how we can build on that. 81-year-old male, history of type 2 diabetes on oral meds, no other comorbidities right before the vaccine, so it depends on where you are and the eligibility. You heard about a patient, a loved one, where the URI symptoms, a little bit of scratchy throat, and then the PCR comes back positive. Next, the 6 days, and I'm going to relate that picture, clinical picture, to the illustration of the disease as we know it. Start developing the dyspnea, the hypoxemia, and now 90% on room air. With that history of smoking, start talking about maybe it's the time to come to the hospital. CRP at 12, the D-dimer at 3, and we all developed these clinical pathways for admission for COVID-19 patients. Next slide, please. Now in the hospital, so this is day number 3, but the hospital day number, total day number 9, hospital day number 3, 88%, and non-rebreather. So that progression would fit the majority of the patients based on the age and the comorbidities, if any, but that's why we need to be a little bit more cautious when we document the days and what would be the treatments. And I'm going to just go, next slide, please, over what we know so far that's been working and endorsed by the guidelines. So with this is a illustration by Rajesh Gandhi and General that appear in the journal, where we know the viremia or the viral replication, it would be the start when you have the mild illness, and then unfortunately that would overlap with the inflammation. It's been described as a cytokine storm. I'm not an immunologist, but we know that cytokine storm might be a description that we're using. Inflammation surge is what we've been describing. And please keep in mind that this treatment of COVID-19 would really depend on that progression and the staging and classification and the clinical progression that will be discussed in this talk. But please keep in mind, we start always with the viremia, very indolent, but then when you get to the hospital, unfortunately, that inflammation would be the prominent phenotype feature of the disease. So this is a simplistic, more clinical management. We know that the monoclonal antibodies, what been approved under the emergency authorization or in the process, it been working outpatient, or at least in the clinical trials of curve disease. Please remember that, and I'm going to restrict it more for the NIH guidelines, that it not been recommended to use these monoclonal antibodies during hospitalization, and that again depends on where the viral or the viremia phase and the inflammation phase, where the patient comes in the hospital. We know from the guideline, the top, remdesivir with dexa alone. All alternatives where we're not able to use the corticosteroids been endorsed across the board, and I hope it is in your hospital, it's in your health system as a clinical pathway to treat. We know Tosi is also been considered and been discussed, and there are many studies to support. We're not here to debate that. We want to focus on the patient. And convalescent plasma, it's been discussed. I would tell you to use your clinical discretion, but there is a debate about really what we're treating here, especially I'm going to relate it to that variance, where if you take a plasma from a couple months ago and try to give it back to a patient, that we have a shift in the paradigms of the variants that might not be something is helpful. So we're still in that top part, remdesivir, dexa, or alternatives, and that's the NIH guidance. So in our case, the patient received everything. So this is very important, received remdesivir, dexa, and Tosi. And I hope that would be the foundation of the care and what we will be helping our patients, the 5,000 every day they get admitted to US hospitals. Thank you very much. I'll be on the sidelines taking any questions. Thank you. Ramesh?
Definitely. Thank you, Dr. Barkuda, for the overview of the presentation. I encourage the people to ask questions so that we can kind of present it during the presentation. I'm going to go to the next presenter. It's Clinical Management and Coagulopathy Updates by Dr. William Garneau. Thank you, Dr. Garneau.
Thanks. So I'm going to talk briefly about clinical management, which I'm sure at this point we're all fairly familiar with, and then some updates as far as anticoagulation, which has been something that has changed pretty dynamically over the past year. So we can go to the next slide. So the levels of illness, I think this is something that we're all familiar with at this time. Also, we kind of touched on it in the last presentation, but you've got your pre-symptomatic individuals. These are patients who are maybe picked up, they got a routine swab, they're traveling or something, and they don't have any symptoms, obviously quarantining. There's folks who have mild illness, maybe they're talking to their primary care doctor, they're quarantining at home, monitoring the symptoms. Primarily the patients that we as hospital medicine doctors are taking care of are going to be these moderate and severe illness, as well as critically ill patients. These severe illness patients would be anyone whose oxygen saturation is less than 94, who's requiring supplemental oxygen. And then critical illness are these patients, as we mentioned in the last presentation, like a woman requiring a non-rebreather, who may need to be intubated or high flow oxygen. Okay, so we're at this time, I would assume everyone is fairly familiar, has taken care of some COVID patients. This is the majority of what I've done over the past years, seen and worked through a variety of paradigms. You've got your newly admitted patient, and I'm sure people have seen a patient quickly changes. They're in the ED, they're on 2 liters, and then suddenly they're on high flow. So, how do you find the right patient, or how do you get the patient to the right level of care? So when I'm thinking about that, you can think about day of illness. What do they look like? I think one of the challenges has been we were triaging patients and not seeing them, leaving them in the emergency room. And a lot of times that was difficult because there's a lot that you gain just by seeing their work of breathing. Are they able to speak and talk? And things change between the hours of when they're in the ED. Sometimes patients get a lot better just with a little bit of oxygen and some dexamethasone. Questions that I often ask the patients: are you able to walk can you walk to the bathroom? Did you walk from the parking lot to the ED? Or did they call EMS? And what percentage of their usual state of health? So do they feel like 10%? They feel like they got knocked over by a truck? Or are they just at 50%? That kind of, I will ask that going forward to know, do they feel like they're getting better? We've all seen that, vital signs, tachycardia, tachypnea. Patients are oftentimes, I feel like, hypoxic at home, and they call EMS, they go to the hospital, and then they're, in the 80s. They've not been eating or drinking, high fevers and diarrhea, and that's kind of the presenting kind of picture. I don't think I've seen that many heart failure, where they're needing to be diuresed on admission. So you're getting the typical CBC, CMP, and then there's inflammatory markers like ferritin, CRP, and D-dimer, which I feel like are helpful early to stratify, see where you are, and then can be used in the future to serially monitor the patient. Did the D-dimer start very high? Is it going down? Did it change in conjunction with a change in their respiratory status? So if the patient's oxygen status is less than 94, we're going to be starting dexamethasone, generally that's 6 milligrams daily. That's going to be a 10-day course, and then remdesivir, generally if it's within 10 days and there's not their symptom onset, they have a normal kidney function, and they don't have a ALT that's very high, you can generally start remdesivir. One other thing I would just make sure that folks are thinking about is Dvt prophylaxis. I know that we've seen a lot of blood clots with COVID, getting heparin or Lovenox ordered for the patient. And then some patients will do awake proning. They may not tolerate it if they're larger or if they have back issues, but actually having a patient who's awake lay on their belly, generally you can see a pretty significant oxygenation change just by doing that maneuver. Several days into the illness, say the patient had been at home and then had had a sudden deterioration, they present, instead of having lymphopenia, but they have leukocytosis, there's 15% bands, they're rigoring. That's the patient that I'm thinking, is there a secondary bacterial infection on top of the COVID that they've been set up for? And I think my threshold for ordering empiric antibiotics is going to be different depending on those kind of features, where they are in terms of the illness, and then some of these things like bands. If the patient has a very high O2 requirement, an elevated D-dimer, history of clots, I'm definitely thinking about a CTA. Logistically, getting a CTA oftentimes is very difficult for these patients on a COVID unit, requires the CT scanner to be decontaminated. So sometimes that can be if they are moving from the ED, sometimes if they're stable, getting that CTA, if they are a patient who you're thinking about may have a PE, that may be a moment in time when you can get that imaging, because that will obviously change what you do. Now the trajectory can change on admission, it can change during the admission. I think that seeing how they initially respond to generally fluids and some steroids as well as oxygen, a lot of patients will report, hey doc, I'm feeling a lot better now, even from the 4 hours that they were in the emergency to being on the floor with you. Things that I think about, comorbidities such as the BMIs of 50 and these restrictive physiologies, that's going to be somebody who's going to have a much harder time with COVID. I don't know if there's a physiologic reason, but there is just, I think, a mechanical reason. And then age has been demonstrated time and time again to be associated with poor outcomes. You see a lot of patients, I'm sure that you've taken care of, especially patients with some measures of dementia. Now you've got them isolated in the hospital, their family's not there, they can't eat, drink, and now they're in a hospital, and then they could aspirate, they can all have all these different problems there, and they're hypoxic now, and you do see those patients tend to do worse. Try to obviously get family if they can call in, if they can Zoom, things like that. And then we're seeing more and more that immunosuppression, especially B-cell depleted patients, do have a different and more severe course. Throughout the admission, obviously, we're monitoring the oxygen, making serial assessments. That can be daily, that could be a couple times a week of these inflammatory markers. And I'm asking them, are they eating? You know, how do they look? You know, you learn a lot just by seeing the patient. Are they able to now walk to the room? Are they able to sit in the chair, whereas they were just laying in the bed before? Did they feel like they were improving? You know, the patient will say, hey, doc, I'm feeling good. And one thing I've built into my practice is really having the patient ambulate in front of me, maybe for a minute or two, have the pulse ox on them, and then just really they show you that they're ready to go because the oxygen, you know, they're able to move around, they don't get short of breath, rather than necessarily having the nurse or someone else perform an ambulatory SAT. And then I've even had patients say, hey, can you get an oximeter? This is what it is. I'll pull it up on my phone, I'll show it to them. They can either get it through home care or get their family member to buy it online. And that's a way I feel like a little insurance policy that, hey, if things change, if they do get a PE when they're at home and things are different, then they have a way beside just you know, to check objectively what's going on with their oxygen. So real quick, I'll talk about kind of some of the trials and some of the changes that we're seeing as far as anticoagulation with COVID. So I'm sure everyone has noticed that early in the pandemic, especially you know, studies from China and New York, we were seeing extraordinarily high rates of blood clots that were associated with COVID. The mechanism is probably multifactorial. You've got ACE receptor cells that are both in the endothelium and the lungs. So that's, I think, why this virus is so virulent, is you have both, it attacks the cells that, you know, can oxygenate, and then also it creates this, it kills the cells in our, that deliver blood to all of our different organs. You see these different, and then that sets up a milieu where you can get blood clots, both arterial and venous. Early on, I remember, you know, you couldn't even get an X-ray, and now obviously we've been able to, now people can get MRIs and all these things, but as we touched on, it can be difficult logistically to get these things, and so people are making decisions clinically without necessarily having an objective, you know, proof of a clot. Early on, we saw centers doing intermediate treatment dose regimens based on clinical gestalt, the lab values, and then patients were even going home with short courses of anticoagulation who might not even have been demonstrated to have a blood clot. There was a recent meta-analysis in CHEST that looked at various studies that have been done on the prevalence of clotting, and it did demonstrate that there is a preponderance. You know, 17% of the patients that were in these studies did have a venous thromboembolism. The majority of those were the DVT at 12%. You had a very high rate of PE at 7%, and then also a fairly high rate of bleeding among these patients. The themes were that you had higher rates of clotting. This is, I guess, not surprising in studies that screened all comers rather than those that were picked up on clinical diagnosis. And then you had a demonstration of higher rates in ICU of, you know, 28% almost, and versus ward patients, but still a very high level of clotting there. So one question that I've thought about is, you know, did clotting change over the pandemic? You know, I think March, as we mentioned before, is a different time than March 2021. We've had different therapies come online. We have remdesivir, we now have dexamethasone. Obviously, there's less inflammation. These are antivirals. You'd expect that there'd be less maybe damage that would be causing clotting. We have more testing. That was the big problem initially. We have protocols for getting imaging. And one thing that I personally thought of is that as we as clinicians have realized more and more that this is a hypercoagulable state, our practice is changing. And there's a neat study that came out, and it showed that the patients who did have COVID were both prescribed and received a higher percentage of their Dvt prophylaxis. So this is, and that I think has changed probably than March, when people maybe weren't realizing, you know, that this was an essential part of treatment for patients who are hospitalized. These are some studies that have just come out in the last few months, and these are looking at the different dosages, because that's, I think, a remaining question for all of us, is what level of anticoagulation should we do? You know, there's people who, you have the low dose, you have these sort of intermediate doses, and then there's, you know, obviously full therapeutic. This was a study that was in Annals, and it was a multi-center emulation model, so trying to sort of recreate at RCT You had 3,000 patients who, and these are ICU patients, so these studies are not necessarily in our patients, but higher level. And these were patients who received either therapeutic anticoagulation or no therapeutic anticoagulation within that first 2 days of ICU admission. And they found, as you can see in the lower right corner, there's no difference in survival, but you did have higher bleeding in the therapeutic anticoagulation group. And you saw that VTE was associated with male, gender, and D-dimer. And this is the inspiration study. So this just came out in JAMA. I think this was a great contribution to the literature. So multi-center, this is an RCT, okay? So we feel a little bit more, this is a pretty good a way of looking at treatments. We have 500, again, ICU patients, and this was intermediate versus standard Dvt prophylaxis with the addition of a statin. So, intermediate Dvt prophylaxis did not improve the rate of venous or arterial thrombus, neither for ECMO or mortality. And then there was a non-significant increase in bleeding among those who were receiving the higher dose of treatment. And then this was another RCT. This was a small study in Iran of 20 ICU patients who were randomized to either therapeutic or standard Dvt prophylaxis. Just to jump down to the treatment, so they did see a difference in the PaO2 over FiO2. So this is a surrogate marker of oxygenation and ventilator-free days. So not a survival difference, but I would just focus on the exclusion criteria where they excluded patients who were going to die within 24 hours, those who had advanced heart, liver failure, kidney failure, cancer, age over 85, high pressure. They're eliminating a very large number of patients who would probably be those ones who might bleed, who might do poorly. And so what I took away from this is that there is maybe a selected group of patients who have a low risk of bleeding for whom therapeutic AC could be beneficial, but I think patient selection was kind of highlighted. And this was not even, this was a 20 patient study, so it was not powered for, to see mortality. And so I think you can make limited sort of takeaway from this. And then just to kind of look at the future, we have a very large, so there's this, the NIH had combined Remap, ACT4, and these, there's a Canadian study, the ATP-ACC study, and they actually combined these studies to create a larger base of patients, and this is going to give us, I think, pretty definitive information about what the role of anticoagulation is. Interestingly, there's been 2 press releases in the last few months. One made national news, which was that the study actually suspended enrollment for the ICU patients in the therapeutic treatment arm due to harm. So again, that's that same signal that we saw before, which is that there's that ICU, all comers getting treatment dose, maybe bleeding is gonna cause harm versus whatever benefit you're getting from higher doses of anticoagulation. Interestingly, in the ward patients, moderate disease patients, full dose anticoagulation was superior. So the full results have not been published. I think we will need to kind of analyze those. But some interesting that it sounds like there's definitely some patient selection features which are starting to emerge. So the future directions, there's about 75 randomized control trials that were ongoing as of December. There's all manner of different things being studied: systemic anticoagulation, even inhaled heparin, DOACs are being studied, inpatient, outpatient, ward, ICU. How do we monitor? Do we use 10A levels, varying levels of treatment? What is the role of antiplatelets? Should patients be going home on prophylaxis? I think these are all questions that we all have experienced. I think we'll have more answers, going forward. So takeaways, obviously the trajectory and comorbidities are important. Dvt prophylaxis really should be ordered unless there's a strong contraindication. D-dimer, other inflammatory markers can give you some data as you go along. Empiric full dose, it seems may be harmful except in a select circumstances. We'll have more data soon. Data can be conflicting, as we've already seen with Tosalisimab, and the meta-analysis of these studies will be very important.
Thank you, Dr. Garneau. This is a very interesting topic, given that multiple people have multiple opinions when COVID started, and with all the data coming in, I'm kind of impressed with the slide where ICU patients, where the study has to be stopped, versus the moderate patients where its therapeutic benefits. We have multiple questions on your topic, but I'm going to take one question and we'll keep the other questions at the end of the webinar. This is the first question they ask. Clinically or anecdotally, could a person who has recovered from COVID-19 suffer a blood clot even if the inflammatory markers in the blood tests appear normal? So our question is, if the inflammatory markers are normal, someone who has recovered from COVID-19, is there like blood clots risk?
Yeah, I think that I don't know if we know exactly how long that risk exists, but if you think about the patient is going to maybe not be moving around as much, that's a risk unto itself. And so I have wondered, do you give the patient anticoagulation to go home with? I think that there's been a lot of study in surgery patients and other medical patients, and generally, except for in very specific circumstances, the harm of the bleeding risk does exceed the risk, the benefit of preventing a blood clot. And so I think that unless the patient's really going to be not mobile, maybe they had a history of clots, they have cancer, things like that are going to add to the risk of we don't know what the COVID risk necessarily adds. It does seem to be a very significant risk. But I think that a patient, and they could come home, and unfortunately, this is part of it is uncertainty. I think you have to make a risk benefit, and you can talk to the patient and say, hey, if you do, if your legs start swelling, if you feel short of breath, come back, and because this is something I'm worried about is you getting a blood clot.
Thank you. Yeah, that's a question we do get most of the times when patients are going to skilled nursing facility, or then I would usually put in the discharge summary telling them, depending on how the patient looks when he is in the rehab, probably that's something that under supervision you can do it. Okay, cool. Thank you, Dr. Garneau. I'm gonna switch to the next topic. Chris, okay. The next topic of presentation is COVID-19 therapeutics for hospitalized patient by Dr. Paul Atwater. Thank you, Dr. Atwater.
Thank you so much for the introduction. And Dr. Barkuda set the stage very well, and Dr. Garneau about how really, I think as clinicians, you're weighing a lot of aspects. There's a lot of art of medicine as well as knowing the science. But what my task is to try in a very brief amount of time, just review how you might make some therapeutic choices. And so we might start off with this case study of a 63-year-old man who's on infliximab for psoriatic arthritis, develops typical symptoms, has not yet been immunized, but importantly presents rather early, just 3 days into onset of symptoms, and has characteristic findings and requires oxygen. And the question is, what treatments might help this patient? So next slide. The first drug which received emergency use authorization was the antiviral remdesivir, originally purposed for Ebola. It's an intravenous drug that's a prodrug that needs to be metabolized, but this NIH-sponsored trial really put the drug on the map and was not large enough to show a mortality benefit, although there was a trend. But essentially, early in the pandemic course, lessened time to recovery by 5 days. Next slide. And if you take a deeper dive into this, the patients that really, the subgroup that drove this were patients that required oxygen. But if you go to the next slide, the group that really didn't were those later in illness, many days into illness that landed on ventilation, would be in the ICU, and there was very little difference. And this makes some sense for an antiviral compound. The drug itself had very few adverse events in the trial, actually less than placebo generally, which tells you about the severity of illness of the coronavirus. There is caution not to use it with elevated increased liver function tests because this drug can drive that to be worse. Now, this pivotal study overall led to the fact that this is the only drug fully approved by the FDA for treatment. We don't have time to go into other studies, and including the large recovery trial. I'm sorry, the large trial, WHO sponsored, which did not show benefit, but that was a pragmatic trial performed in other countries, never really had a placebo course. So I think here in the United States, the drug has a firm place, although others question its use. It's clear that using it early is probably better. There is an issue about renal failure. This is a frequent question because the packaging says it should not be used, but it's because of the carrier, the cyclodextran. And we've had the same carrier with the antifungal drug voriconazole. We've given it intravenously in renal failure for years, for long term, without an issue. And so we have no difficulties administering it in our hospital, and the medical literature seems to support that. The drug is improved for ages 12 and older, but not in younger. And so when to use it, most studies suggest you want to use it less than 10 days into illness. If you require oxygen, those who are admitted for other reasons not on oxygen early in illness, unclear if they would benefit or not because there weren't enough patients in the studies, but may have some potential for people at high risk for progression. Next slide. So here are the current recommendations. So both the NIH and the Infectious Diseases Society of America endorse use for patients that are on supplemental oxygen, but not ill enough, at least for the NIH, to land in the ICU or be on ECMO. IDSA still has a sort of broader indication, which was how some of the earlier studies were organized before the ACT 1 trial was published. Next slide. Now, the next agent that someone might consider as a clinician would be convalescent plasma. As Dr. Barcuda mentioned, this really has a checkered track record. We don't really have a large randomized controlled trial yet that shows positive results. I will say part of the problem here, much like with remdesivir, is often the plasma was maybe of low titer or was given later in illness when you wouldn't expect the plasma to have a benefit. So here are two studies that I think I might at least review with you to see if it makes some difference. This is from the large expanded access trial earlier last year, coordinated by the Mayo Clinic. It was open label, not randomized, but they did have over 35,000 patients, but took a subset of people who they had the titer on, and they also had timing. And what they found is that if you used high titer and you gave it before patients were ill enough to be in the ICU, it appeared to have impact on mortality. So I think this was one of the reasons that this truly drove the FDA to make it an expanded use authorization last summer. The other study I might point to is a smaller one from Argentina, and this was an outpatient one. And of course, the convalescent plasma in the United States is only authorized for inpatient use, but they gave it to patients with less than 72 hours of symptoms, just like our patient in this case, and they only used high titer. And you can see here, there was a definite improvement in reduction to severe illness in those that received the plasma. So again, I think this gets to the biological plausibility that early use may have a role, especially in patients such as the elderly that are at high risk. So at least how I think of using it is if someone is very early in illness, within 3 days of symptom onset or early in the hospitalization, or the other group, which hasn't been well studied, but there's emerging data, are people that can't mount good antibody responses, someone that may be on rituximab or have CLL, you may want to consider convalescent plasma, especially in those groups. Now, pivoting from the antivirals, we have the immunomodulators, and I think you're all familiar with this arm of the pragmatic recovery trial in the UK. Dexamethasone was studied, and much to everyone's surprise, this had a whopping effect on mortality, especially for patients in the ICU, with a marked decrease in mortality from over 40% to 30%. Even those who are on supplemental oxygen had a modest benefit, but importantly, for those that did not require oxygen, there was actually a trend towards worsened outcomes. Next slide. So this was the first drug to clearly show mortality. It's, I think, been widely adopted across the globe to help people that seem to be worsening with elevated inflammatory markers and fever and heading to higher dose oxygen in the ICU. The mortality in the UK trial was much higher than we saw in the United States, but it also, there were other corticosteroid trials showing benefit. So this seems to clearly have a place in coronavirus-induced respiratory progressive illness. Next slide. Now, the one that's a bit more controversial, as Dr. Barkuda had mentioned, is Tosalisimab. This had a lot of premise based on inhibiting a cytokine storm, because that's what it does, and it's actually FDA approved when people get CAR T cell therapy for cancers and have an intense cytokine storm. So the Chinese guidelines adopted it for its use here against COVID. And essentially all the studies that used it as a single agent failed. It did not work, except for the next slide, the Impactus study, which was the last study here when this was published in the fall, which did show an improvement with less ventilation and death as a composite endpoint. But why is that? And I don't know if it's just the trial, but one of the clear aspects where this trial was done later, and over 80% of the people in this trial were also on steroids. Next slide. And I will just mention two more recent Tosalisimab trials. We'll first talk about the Remap Cap Trial. This trial looked at two different anti-IL-6 receptor blockers, but they gave it to only people who were quite ill on high flow oxygen or only in their first day in the ICU. But look at the difference here. Again, a high percentage also received dexamethasone. And what they found was in this very ill group, that there was a 10-day improvement in organ-free support and also decreased mortality compared to placebo. This was published in the New England Journal. Next slide. Then the recovery trial, which you already heard about from dexamethasone, also had a Tosalisimab arm. Here, what's interesting is that, again, you'll find that a substantial proportion of these patients were also on dexamethasone. And those that, again, seem to be getting worse and had high oxygen requirements and high inflammatory marker with an elevated CRP appeared to benefit both in terms of needing less mechanical ventilation, less mortality, and more discharges. Next slide. And just diving in briefly into the recovery trial, what's clear is that if people were on steroids, which were 82% of this trial, the Tosalisimab appeared to yield benefit. And so that's, as you look further down on this whisker plot, seems to be the case. And then if you look at all the studies in Tosalisimab, generally there seems to be a trend towards improvement, but most of that is likely driven by the three studies I just mentioned, where there was concomitant high utilization of dexamethasone. So in summary, what the NIH looked at is that it might be considered to be used with dexamethasone in your patients that are on high flow oxygen or heading into the ICU within a day. IDSA came in a little bit lower certainty of evidence, mainly because I think they were looking at the totality, including the monotherapy. But I think this drug does deserve some consideration in your more ill patients as whether it could be combined with dexamethasone. Next slide. So going back to our case, remdesivir was started because the patient was early, and the patient did get high titer convalescent plasma from our blood bank. But what wasn't used, which may be surprising, was dexamethasone. I don't have time, but there's some emerging data that the effect of plasma may be negated by the dexamethasone, and he wasn't ill enough for Tosalisimab. The patient did improve, and I would also say it would be completely reasonable to just use dexamethasone with plasma or without plasma but that's one of those clinical judgment calls at this stage based on imperfect data. A second case, just to briefly describe, is this 28-year-old woman admitted for COVID pneumonia. She's 32 weeks gestation, uncomplicated, but has been ill for a full week with cough, but then was getting worse in the last day. And this is exactly when that cytokine storm or the hyperinflammation seems to take hold. So just quickly talking about this special population, remdesivir, there's very limited data, and so typically you always read this, clinician, patient must weigh the risks and benefits. I would say it's a little too late in illness to likely give a lot of benefit. Convalescent plasma, the same. Once you enter this hyperinflammatory phase, it's probably too late. Dexamethasone, well, the gynecologist will probably say not to use it because it enhances unneeded fetal lung maturation, so you would use prednisolone or hydrocortisone. And there's very limited data on Tosalisimab, but it is used in rheumatoid arthritis patients who are pregnant. And then the third case, just in closing, so we can get to some questions quickly, is a 75-year-old woman with heart failure who has a cough and fever for only 2 days, no oxygen. She got a Pfizer vaccine 1 month ago that she had completed, so she probably has had antibody responses. Clearly still the efficacy in the real world in this kind of population with the Pfizer vaccine or Moderna is probably 90 to 92% based on studies. What would you offer her? Well, probably supportive care, but there's still a risk for her to progress to illness. What we don't know is whether monoclonal antibodies have a role at this stage. I think it would not be unreasonable since she's so early to refer her to one of these, but it's unclear if they have a role for patients who are immunized. I think this is an unanswered question, but just wanted to put up this scenario because I think we'll be seeing this a bit more and more over the next couple weeks. So briefly, there are 2 monoclonal antibodies now. Bamlanivimab is no longer being distributed as monotherapy, so you have 2 combination monoclonal antibodies. They're only reserved for outpatients who have high risks for severe COVID-19. They both appear to reduce viral load and reduce the risk. Well, I'm sorry, only one appears to have proven so far to reduce viral load, but what both have done, as you can see here, is reduce the chances of the patient landing into the ED or hospitalized, but on average, in these studies, patients have gotten the drug by day 4. Lastly, I'll just touch on the variants, which Dr. Barkuda did. This is why bamlanivimab is no longer given alone, is because some of these newer variants had a marked reduction in effect of the drug, and anything over 1,000 is likely thought to correlate with reduced in vivo activity. And then lastly, although there's some reduction with bamlanivimab and etesivimab and no change with the Regeneron product, casirivimab and divimab, both still seem to have activity against the common variants that are being described increasingly in the United States. So just briefly in closing, it's been really hard to show antiviral effectiveness on mortality in hospitalized patients, whether it's plasma or remdesivir, but I think both potentially have a role. You have dexamethasone and tocilizumab for the hyperinflammatory phase considerations. There's also baricitinib, which we didn't have time to discuss. And you'll be hearing more about the immunomodulatory drugs, although there are a few oral antivirals that are in the pipeline that we may hear about by this summer. And I don't know if we have time for questions, but thank you for the opportunity to discuss some of the data behind our clinical therapeutics.
Yes, thank you, Dr. Atwater. I want to ask the first question to Dr. Barkuda. And the question is, what are your thoughts on using procalcitonin in the setting of worsening clinical symptoms with COVID pneumonia to consider adding antibacterial for possible bacterial superinfection?
So that's an excellent question. Thank you, Jose. procalcitonin without COVID is pretty much driving our antibiotic utilization in the context of stewardship. So I'm a believer that less antibiotics is better, and I live in an institute. There have been many pathways for us to make sure we get the right treatment to the right patient. The short answer is we do not know. So we do have a protocol, the COVID protocol, with a set of labs that we check pro-cal. Retrospectively, the antibiotics use is driven by radiology findings and clinical progression, not just pro-cal itself. So I would say in general, and I'm going to touch on the question also that was asked about anticoagulation, is proceed with caution. What we knew traditionally might not apply to COVID per se, and the data might change. The treatment is changing what we do month to month. When you're ordering a pro-cal to look at the pneumonia or justify your antibiotics use, I think you got your answer while you're ordering that. Market increase, I would probably think about antibiotics, but the guidelines is pretty much the antibiotics, except the specific superimposed bacterial infection, is really not recommended, to say the least. And that is not just given what we started with, which is azithromycin, the 2 trials, and also doxy. It's a zone that it really depends on the clinical picture. And that's similar to the question that was asked earlier about the anticoagulation. So the risk post-discharge, it doesn't go to 0. We knew that from many trials that use the term extended Dvt prophylaxis. And it really depends on the clinical picture, but the inflammation in COVID is really what's driving that risk that might be much higher than any other disease entity.
Thank you, Dr. Barkuda. I definitely agree about antibiotic stewardship, particularly in COVID-19. Just to add to what you've already kind of alluded to regarding anticoagulations, I'm going to skip some of the vaccine questions for now, since we didn't really cover a lot of the vaccines. But there was a question here about clots. If there's a high rate of clotting in COVID patients, is it worth adding anticoagulants to the treatment protocol? And I'm going to have Dr. Garneau answer this question. Is there anything more to add to that, Dr. Garneau?
Yeah, so I would consider that COVID is a risk factor so strong that you would, unless there was a reason to not, they're bleeding or there's some contraindication, the platelets are 10 or something like that, I'm ordering anticoagulation.
Jose,
and that's prophylaxis.
Perfect. So I would like to add to Dr. Garneau also, you really walk in a fine line between the risk and benefits, right? So we know from the JAMA publication that this half dose, halfway in between, might not be really curbing the disease, but the full anticoagulation might be a little bit on the risk side, right, Will?
Exactly.
Perfect.
And I think I personally saw that the therapeutic anticoagulation, I think people were using that more often, especially when we weren't able to get, like the sonographers weren't doing ultrasounds. So you really were in this tough position of trying, but I think that some is definitely better than nothing. I think that just getting a little bit of anticoagulation, whether it's the 40 of Lovenox, is doing a lot. And I think that maybe that's these mortality rates, while we still have very high death rates in America, I think that our success of treating patients is probably in some part due to the more standard use of anticoagulation prophylaxis.
I'll do the next question for Dr. Atwater. In a patient 2 weeks out from start of symptoms, comes in with fever, persistent cough, and dyspnea, elevated procal, thus treated for secondary bacterial pneumonia, would you add dexamethasone for hypoxia?
Well, I think these are one of the clinical judgment calls. Typically, if I think someone is ill enough and heading to the ICU, we will usually add dexamethasone to antibacterials, or they're already on dexamethasone. And then more commonly, we might add antibacterials because it's so hard to tell if someone has bacterial superinfection, which clearly afflicts perhaps 20% or more of people. Two additional points I'll just quickly make. One is that procalcitonin is not proven to be quite as reliable in this setting, and indeed it sort of has a mixed bag for helping to understand when to add antibacterials. It may have better importance to know when to stop it. The second is just for everyone to remember, especially with the more ill patients, we've been seeing a lot of kappa, and that's coronavirus-associated pulmonary aspergillosis, which can also occur after influenza. So we usually are checking beta-D glucans and serum galactomanins. If we're usually not performing lavage, although that's another opportunity, but we're often also adding empiric voriconazole for our most ill patients.
Thank you.
Yeah, I would just second that if a patient is declining and they're on the standard therapies and they're especially a couple weeks out, while the sensitivity of those fungal markers might not be high, again, the risk of missing a fungal infection that is I think going to outweigh the risk of giving somebody a medicine that they maybe don't need.
Thank you. I'll ask one question to kind of see maybe quick answers. Are you seeing patients or people who are vaccinated against COVID-19 in ICU with COVID-19? Anyone can take it.
I would like maybe to take a stab at it. So we know from the data that's been reported so far that after 2 doses of vaccination, and I hope everybody on this call and the audience got their vaccination, the disease tend to be mild. But there is, I think this is the part about COVID is the humility and not to be assertive, trying to learn my lesson, but I received calls about severe cases, but the question really, there is no one size fits all, but on the population level, it tend to bring a little bit milder disease. Maybe Dr. Atwater would weigh in on this.
Yeah, thank you. I think it's an excellent question. Certainly, there have been patients who develop severe COVID-19 who have been immunized. I think these are people that tend to be elderly or have immunodeficiencies, or might have high risks to begin with. We've seen a handful, and it tends to be more in our immunosuppressed population. But again, I think there's this sense for many patients that the vaccine offers 100% protection, and that's not the case, especially with community rates so high. So it's really a cautionary note for our patients. I'll also mention that many hospitals now, for patients that are unimmunized, are offering, for example, the Janssen J&J vaccine at discharge, just like we do with the Pneumovax, for example, to offer protection with the one-shot vaccine if they have it available.
Have you seen patients who had COVID-19 develop autoimmune conditions, and which vaccination is best suited for people with autoimmune conditions?
Yeah, so, well, of course, there's this ITP question that's come out, both with native disease and the vaccine. Also, I would mention there are, of course, the children that develop MISC, and there's probably an adult analog that we see a month or 4 to 8 weeks afterwards, it seems, after COVID-19 that have this delayed inflammatory response. Whether that's really autoimmune or a delayed inflammatory response to viral antigens is unclear. Almost all viruses can be associated with some sort of post infectious autoimmune disease, whether it's an arthritis syndrome, acute demyelinating encephalomyelitis. So there's definitely a handful of those out there. It's always hard to know if it's truly an association or not. And I think we'll learn more and more as we get better epidemiological data.
And just to add to Dr. Atwater, these clinics are the clinics that we're now seeing in the academic medical centers. It has a label that probably would really be a blanket, the long haulers, but I think we're getting most of the complications kind of funneling through these channels. And I would encourage the referral, especially that we know it might not be just the viremic phase in the early inflammation or the cytokine phase, as Dr. Atwater said, that we might see more and more of that clinical phenotype as a long term. I know Hopkins has the clinic. We have one here. We have a couple in Boston. I heard about 3 so far in New York. Which is excellent to look at that epidemiology aspect of the post-acute care.
I thank all the speakers for excellent presentations, and I personally learned a lot of things, but I think 1 hour is less time to kind of discuss our COVID-19. But thank you, Dr. Barkuda, Dr. Garneau, and Dr. Atwater for this excellent presentation. I hope all our audience enjoyed it.
Thank you very much.
Thank you.
Thank you.
And thank you for everyone that's taking care of COVID-19 patients.